Ni hao. Ni hao ma. This is as much as I can go with my Chinese. You call that baby steps, right? Right. So today we're going to talk about non-surgical treatment of urinary incontinence. But before we start, let me welcome you and thank our sponsors, Medlander and Global Healing Solution, for inviting me and making this talk possible. So my name is Dr Dakalo Muavha. I'm a head of clinical unit in Petersburg Hospital, and I'm also a urogynaecologist subspecialist in University of Limpopo, which is situated in Africa's Eden, aka Limpopo province, which is the northern part of South Africa. So in this presentation, we will first talk about what is urinary incontinence and give you some different types of urinary incontinence. Then we go to what actually caused this urinary incontinence. And finally, we will then talk about what do you do to fix this problem, non-surgical treatment of this urinary incontinence. So let's begin. Urinary incontinence is defined by the International Continence Society as a complaint of any involuntary leakage of urine. This problem, believe me, is very common in women. Even though it's underreported and undertreated, we have more than 200 million people worldwide living with this urinary incontinence. I hear someone say, so what, Dr. Moaba? Urinary incontinence is just part of growing up. Not exactly. Urinary incontinence affects real lives. It can affect any group of individuals, whether you are middle-aged, whether you are a child, whether you are elderly, it can affect anyone. And urinary incontinence can affect people physically. For example, patients with urinary incontinence, they are constantly wet. As a result, they have skin breakdown. They have recurrent urinary tract infection. They sometimes can fall when they are rushing to the toilet because of urgency. With a fall can result in hip fracture, more especially in elderly women. With hip fracture can result in thromboembolism. With thromboembolism, patients can die. Not only that, socioeconomically, urinary incontinence have a big impact in patients with urinary incontinence. For example, these patients, they self-isolate, they avoid intimacy, and the adult diapers, which some patients use to keep themselves dry, is not cheap. I'll give you an example. In USA alone, they spend around $16.3 billion every year in management of patients with urinary incontinence. It doesn't end there. Mentally, these patients are always anxious. When they go to a public place like a mall, the first thing they want to know is that where is the bathroom? Because they do not want to be wet in front of everyone. And that can result in depression. And some patients can actually end up committing suicide. So let's talk about the commonest types of urinary incontinence. The first one there is stress urinary incontinence. This is when a person has involuntary leakage of urine on effort, when a person is having exertion, or when a person is sneezing or coughing or laughing. The second one is urge urinary incontinence. This is when there is involuntary leakage of urine accompanied or immediately preceded by urgency, which is a sudden compelling desire to urinate that is very difficult to delay. Whereas the combination of the two, which we call mixed urinary incontinence, is when the involuntary leakage of urine is associated with both urgency and exertion, and on effort, or when you're sneezing or coughing. So that is when both stress urinary incontinence and urge urinary incontinence is there on a single individual. What about overactive bladder syndrome? Overactive bladder syndrome is diagnosed when a patient has a cluster of the following symptoms: urgency or urge urinary incontinence, frequency, and nocturia. But overactive bladder syndrome is a diagnosis of exclusion, meaning you need to exclude infection and other obvious pathology. For us to understand the causes of urinary incontinence, we need to dive in to the mechanism of continence. Normal continence in a woman is a complex coordination between the receptive bladder, which hold and store the urine, and the competent urinary sphincter, the pelvic muscles, and the surrounding connective tissues. The storage of urine is voluntarily controlled and modulated by the pontine maturation center, which is found in the brain. During storage phase of the bladder, the pontine maturation center will stimulate the sympathetic nervous system at thoracolumbar region, which is the hypogastric nerve, but it will inhibit the parasympathetic nervous system at the sacral region, which all inhibit bladder contraction by the detrusor muscle. There's also stimulation of the pudendal nerve so that one can hold urine voluntarily. Voiding begins with relaxation of the urethra. This is followed by activation of the spinal reflex pathway that is coordinated by the pons, and this will increase in parasympathetic transmission to the bladder, initiate detrusor contraction. Whereas this same pathway acts to inhibit the sympathetic pudendal outflow to the urethra, maintaining the urethral relaxation. Detrusor contraction raises the intravesical pressure sufficiently to allow the bladder to empty. So let's talk about when things go wrong, when this mechanism fails. We can start with when there is a failure of storage, where there is detrusor instability. For example, in patients with interstitial cystitis, patients with neurogenic bladder, and patients with overactive bladder syndrome. So when the detrusor instability occurs, patients will have urge urinary incontinence. So stress urinary incontinence occurs when there is failure of urinary sphincter mechanism, which mostly occurs following birth trauma. The first step of management of urinary incontinence is to make the diagnosis. As you already know, medical history and thorough physical examination is fundamental to clinical care. Specifically with urinary incontinence, you would like to know whether the patient has hematuria, whether the patient has recurrent urinary tract infection, whether the patient has previous radiation or pelvic radiation, whether the patient has voiding dysfunction, or on physical examination, is there any abnormal pelvic exam? Because all these findings needs a straight referral to the specialist. Validated questionnaires can be used to discriminate the different types of urinary incontinence. It can also be used to quantify the patient's symptoms, but this is often used in the context of a research. Since the bladder is infamous as an unreliable witness, 3-day bladder diary can also be useful in differentiating the different types of urinary incontinence and also to find out the aggravating factors of urinary incontinence. Urine analysis will be important to rule out urinary tract infection. Post-void residual is another test which can be used, especially in patients with voiding dysfunction, and preferably to use an ultrasound to measure the post-void residual because it's non-invasive compared to using a urinary catheter. What about urodynamics? Urodynamics is not routinely used in all patients with urinary incontinence. It can be used in selected patients with complicated urinary incontinence. Example, patients with voiding dysfunction. A PET test may be used when quantification of urinary incontinence is required. Imaging for patients with urinary incontinence is not routinely used, but for a patient with urinary incontinence associated with fecal incontinence, chronic back pain, neurological fallout, you may need to do an X-ray of the lumbar spine or MRI of the lumbar spine to exclude other causes of these symptoms. So now let's go to what you have been eagerly waiting for. What do you need to do to fix the problem? So the first line of defense in treatment of urinary incontinence is to do simple clinical intervention. You go and treat the patient's comorbidities. If a patient has cardiac failure, chronic renal disease, diabetes, neurological disease, you must treat those conditions and you optimize those conditions. Some of these conditions, patients are actually taking some medication which can worsen urinary incontinence. So you may need to go and adjust some of this treatment. Patients who have constant constipation, you must treat the constipation. But in a patient who has gone through all the possible treatment of urinary incontinence, in a scenario where everything has been tried, containment can be used, such as urinary catheter or using absorbent pad. So other non-surgical treatment is the lifestyle intervention. Patients who drink a lot of caffeine, you will advise them to reduce taking caffeine. You will advise patients who are sedentary and not doing much to start doing physical exercise. You will advise a patient who is drinking 7-8 liters of fluids every day so that they want to lose weight, for example. You will advise them to reduce the fluid intake. And the chronic smokers, you will advise them to reduce smoking or stop smoking altogether. The other non-surgical treatment which has been shown to be effective is behavioral therapy, where you ask the patient to time their void. And this is important so that they can retrain their bladder. The other non-surgical treatment of urinary incontinence is the physical therapies. For example, your pelvic floor muscle exercise, which can be done by the patients alone at home or can be done under supervision by the professional physiotherapist. The other treatment is the electrical stimulation and magnetic stimulation, which I will expand a little bit further in the next 2 slides. And the last example is the posterior percutaneous tibial nerve stimulation. The electrical stimulation therapy, here we use a low-grade electrical current to elicit contractions of the muscles by activating both the nerve and the muscle. This helps to restore the central brain control over the damaged muscles. And this prompts the nervous system to form new connections and reshape neural pathway. This has been shown to be very effective in improving pelvic floor disorder symptoms such as urinary incontinence. With magnetic stimulation therapy, the patient will sit down on the chair that has coils in the seat or under the seat. An electric current is sent into this coil to create a magnetic field that tenses and relaxes the muscles of the pelvis. The advantage of this therapy is that it has a focused energy without decrement. It has in-depth penetration and is also non-invasive and painless. It hasn't shown any side effects at all. So, medical treatment of urinary incontinence. Let's start first by discussing medical treatment of overactive bladder or edge urinary incontinence. This is achieved by antimuscarinic or anticholinergic drugs which inhibit the action of acetylcholine. Acetylcholine is a neurotransmitter in the parasympathetic nervous system, and this results in the relaxation of the smooth muscles or the trousseau muscles. The first antimuscarinic drug is oxybutynin or datropin. Datropin has both antimuscarinic and antispasmodic effects. It reduces incontinence episode by around 83 to 90%. But the percentage of people who report to be totally continent is around 41 to 50%. And the mean reduction in urinary frequency is around 23%. The biggest challenge is that most patients stop taking datropin because of its side effects, such as dry mouth, dizziness, blurred vision, dry eyes, nausea, and vomiting. Tolterodine is a potent antimuscarinic agent for treatment of detrusor overactivity. With similar efficacy as the oxybutynin, but it has lower side effects and lower discontinuation rate by the patients. Darifenacin is an M3 selective receptor antagonist. As a result, lesser side effects than oxybutynin as well. The other antimuscarinic or anticholinergic agent for treatment of overactive bladder is sulfasalazine or Vesicare. Whereas fesoterodine is the newest anticholinergic available for overactive bladder symptoms. It actually shares the same active metabolite as tolterodine. However, fesoterodine is efficiently and extensively metabolized. As a result, patients with overactive bladder on fesoterodine 8 mg showed superior efficacy over tolterodine 4 mg in reduction of urinary incontinence episodes. Trospium has a unique liver metabolic pathway, making it most suitable for patients receiving multiple drugs with cytochrome P450 utilization. The other group of treatment of overactive bladder is beta 3 receptor agonist or mirabegron. Just like the antimuscarinics, it also causes relaxation of the detrusor smooth muscles of the urinary bladder and as a result, increase bladder capacity. Mirabegron is mostly tolerated by the patients with lesser side effects. The common reported side effects are hypertension, nasopharyngitis, UTI, and headache. When it comes to stress urinary incontinence, there is no effective medical treatment for stress urinary incontinence. Medications such as duloxetine should not be used as a first-line treatment for stress urinary incontinence unless the patient herself prefer pharmacological to surgical treatment, or patient is not suitable to surgical treatment of stress urinary incontinence. What about mixed urinary incontinence? For mixed urinary incontinence, of course, we use the same treatment as overactive bladder and for stress urinary incontinence. So your sulfenacin, tolterodine, duloxetine can still be used, including here imipramide, which is also very important to reduce nocturia. What about estrogen replacement therapy? With estrogen, please do not use systemic hormone replacement therapy for treatment of urinary incontinence. You can offer intravaginal estrogen for treatment of overactive bladder symptoms in postmenopausal women with vaginal atrophy. In conclusion, optimum management of patients with urinary incontinence requires a thorough history taking, physical examination, and doing some special investigation to make a correct diagnosis. Once that is done, multidisciplinary team approach is the order of the day. For patients with comorbidities, you might need the physicians to optimize them on those comorbidities. Patients may be stressed or depressed, so they may need a psychologist or a psychiatrist. You will definitely need the physiotherapist to assist with pelvic floor muscle exercise. And of course, there is variety of medical treatment and physical treatment with patients of urinary incontinence before you go to surgical treatment. I thank you.